Hello everyone, and welcome to our presentation on the Glasgow Coma Scale or GCS. I am DocSaab, and today we'll be diving into this foundational tool for neurological assessment. First, let's establish what exactly the Glasgow Coma Scale is. At its core, the GCS is a standardized tool specifically designed for assessing consciousness. Its history dates back to 1974 when it was introduced by two visionary professors from the University of Glasgow, Sir Graham Tisdale and Brian Janet. They developed it with a clear purpose to standardize communication among healthcare professionals about patients' neurological state and to allow for effective monitoring of neurological status in a cases of acute brain injury. The impact of their work has been profound. The GCS is now widely adopted in over 75 countries and is considered a critical tool in both emergency and critical care settings. It's provide a common language for clinicians worldwide. Let's dive a bit deeper into the historical context and development of this important scale. The GCS was developed at a pivotal institution, the Institute for Neurological Sciences, where Tisdale and Janet conducted their groundbreaking work. Its original publication was in the estimated medical journal Lancet in 1974 in an article titled Assessment of Coma and Impaired Consciousness, a Practical Scale. The primary aim behind its creation was to provide an objective, reliable, and reproducible method for assessing unconscious patients. Over time, the GCS has been evolution, undergoing updates and refinements to address variation in assessment techniques that emerge, ensuring its accuracy and relevance continues to this day. The GCS is a fundamentally built upon three core components which are easy to remember by their initial letters E, V, and M. Eye opening. This component assesses the patient's ability to open their eyes, indicating a basic level of arousal and awareness of their surroundings. Verbal response. This evaluates the patient's speech and orientation, giving insight into their cognitive function and ability to communicate. Motor response. This measures the patient's motor ability and their response to commands or painful stimuli, reflecting brain function controlling movement. Now let's break down the detailed scoring criteria for each of these three components. It's important to understand the specific action or responses associated with each score. For eye opening, a score of 4 is given for spontaneous eye opening, meaning the eyes open without any stimulation, 3 for opening eyes to verbal command, 2 for opening to pain, and 1 for no response to or no eye opening at all. For verbal response, a score of 5 means the patient is oriented and converses normally, fully aware of time, place, and person. 4 indicates confused conversation, meaning they speak but are disoriented. 3 is for inappropriate words, where speech may be recognizable but doesn't make sense in context. 2 is for incomprehensible sounds like moaning or groaning, and 1 signifies no response verbally. For motor response, a score of 6 is for obeys commands, following instruction given. 5 for localized pain, meaning they purposefully move to remove a painful stimulus. 4 is for withdraws from pain, pulling a limb away. 3 indicates abnormal flexion, also known as decorticate posturing, a specific abnormal flex arm posture. 2 is for extension, decerebrate posturing, a specific abnormal extended arm posture, and 1 means no response in motor function. The overall approach is that each component is scored individually based on specific criteria, and then these individual scores are summed up to yield a single total GCS scores. Moving on to interpreting GCS scores, this is where the clinical significance truly comes into play. The total score is a simple sum of the individual E, V, and M scores. This score has a defined range, a minimum of 3 representing a completely unresponsive state to a maximum of 15 indicating a fully responsive individual. This course allows for clear severity classification of brain injury. Mild brain injury is typically associated with a GCS score of 13 to 15. Moderate brain injury falls within the range of GCS 9 to 12, and severe brain injury is indicated by a GCS score of 3 to 8. The prognostic value of the GCS is significant. Lower scores, especially in the range of 3 to 5, generally indicate a higher risk of mortality and poorer long-term outcomes for the patient. Despite its widespread utility, the GCS does have a certain limitation and influencing factors that clinicians must consider. One key limitation is its inability to incorporate brainstem reflexes, which are important indicators of neurological function. There are significant challenges with the intubated or sedated patients, as intubation can obscure the verbal response and sedation can affect both verbal and motor responses, making accurate assessment difficult. External factors such as language barriers or pre existing conditions like stroke or dementia can also complicate GCS interpretation. Observer variability can occur due to inconsistencies in assessment technique among different healthcare providers. Furthermore, some critics argue that the 15-point scale can be perceived as complex for rapid application, particularly in fast paced pre hospital environments. It is also important to consider the GCS versus other neurological assessment tools. While the GCS is a cornerstone, other scales offer different advantages. The full outline of unresponsiveness score includes brainstem reflexes and lacks a verbal component, making it particularly useful for intubated patients where verbal response cannot be assessed. The Glasgow Coma Scale pupil score combines the standard GCS with an assessment of pupillary reactivity, providing an enhanced prognostication, especially in traumatic brain injury. The acute physiology and chronic health evaluation APACHE-2 is a broader severity of disease system. While not solely neurological, it's sometimes used in conjunction with or compared to GCS for predicting outcomes in traumatic brain injury. Despite these alternatives, the GCS advantages lies in its simplicity, broad applicability, and its value for rapid assessment in emergencies. The practical applications of the GCS span across a wide array of medical scenarios, making it incredibly versatile tool. In the traumatic brain injury, it is arguably its most common use, serving for initial severity assessment and ongoing monitoring of the patient's condition. In stroke patients, it is used for evaluating a consciousness and monitoring for any neurological impairment or deterioration. Following cardiac arrest, the GCS is a crucial for assessing post-resuscitation neurological recovery and helping to predict long-term outcomes. For non-traumatic coma, it assists in assessing the depth and duration of consciousness impairment caused by various medical conditions not related to physical trauma. In cases of toxic ingestion or overdoses, the GCS is a vital for evaluating the neurological impact of toxins and tracking the patient's response to treatment. Finally, there is an adapted version, the pediatric GCS, which is specifically tailored for infants and children, allowing for appropriate assessment in this unique patient population. In conclusion, the Glasgow Coma Scale has truly earned its place as an indispensable tool. For 5 decades, it has provided a consistent and universally understood method for assessing consciousness. It facilitates communication among medical professionals, standardizes evaluation, and critically guides important medical decisions. It balances utility effectively, remaining highly effective despite its known limitations, and is often complemented by other, more specialized assessment tools. Its continuous impact on emergency, critical care, and trauma settings worldwide is undeniable, making it a fundamental component of modern medical practice. Thank you so much, guys. Please like, share, and subscribe to the DocSaab's Diary.